the certain protocol. ¿Tenemos cuánto tiempo para esto? Vamos en tiempo. Ioannis, adelante.
All right. Thank you. Good afternoon. First of all, I would like to thank the organizers to invite me here. It's not the first time in this very nice country. And this week is a special week because I know you are going to the final against Brazil on Saturday. So I'm wish that you get the gold medal. I don't think we have any Brazilians here in the audience. So when I started to deal with the cornea about 35 years ago, I was thinking from the beginning on that probably we had to find a way to customize the transplantation, the donors, in order to fit better to the eye. And you know very well that when you trephinate a keratoconic eye, the trephination is not rounded, it's irregular, it's oval or has a very certain shape. So this study I've done 22 years ago proved that really, based on the findings from the keratoconus at that time, you can identify the shape of the penetration on the cornea when you do the trephination. So in this case, that time I was thinking that it would be very nice to have a technology which you can use to adapt your donor to the given eye. So today we are very close to do that, of course, and this dream comes a reality today, having the laser in our hands. So I don't like to stick longer here on the femtosecond laser because you are familiar with that, but we had increased several femtos lasers the last couple of years. The last one we get is the Wavelight 200 femto laser, having before the 150 IFS laser for our use in the clinic, either for keratoplasty or for refractive surgery. So now what I'm proposing here is not something very different than what you saw before, like the Z-like or the top hat technique, but it's a small modification which probably can help to seal better the host in the cornea. And I think this pairing could be more easy when you have a controlled way somehow to put your suture, and of course, if you can use less suture, it will be much better. And if we made some time to make corneal transplantation without any suturing, that would be much better, of course. And I think this should be the goal for the future. But in any case, to this stage right now, I think that if we can make it to have less irregular astigmatism and have faster visual rehabilitation, this is a very good step in, for the next generation of cornea transplantation. So if you would like to find the ideal cut, you have to find a way that the cut has to make the donor and the recipient so far that they can match together, and in order to achieve faster, better healing, and of course, to have lower endothelial risk, and if we can do without need of suture, it will be better. So there are several modalities, as Ramon presented before, and he has a very nice experience, of course, all the last years on these different technologies, and he knows very well all the problem we face using one or the other technique. But the major problem here is that, as he said also, that when you go to make a Z-like technique like here, somehow it's difficult to match by suturing the edges of the donor and the recipient. So here what I was proposing is to make a special vertical Z-like cut, in which is feasible to do with the wave light laser now in one shot. That's mean you can make it just in one program. And in this case, I'd like to present one of case which I have done the last 3 or 4 months from now, trying to play a little bit with this vertical Z technology. This is a patient which has been treated with this femtosecond laser, and as I said, with this vertical Z style of pattern. And you will see how this works in this case. This is the pattern how it looks like. It's like a Z pattern, which is a vertical shape, or like an N, which the central part is going deeper and the periphery is going more towards to the periphery. So it makes here a small ankle, which can be identified based on the parameters of the patient in order to have a better fitting. The idea behind is to have a cut like that, and you go for deep, shallow to the periphery in order to have this ankle here, in order that this part of the recipient of the donor fits precisely in the recipient. And having in mind that you have always the intraocular pressure, which is pressurizing the donor against the host, you can expect that you have a kind of a lock effect here. So, and in the same time, this can act also as a guideline to put your suture. It's very easy to do in the surgery room if you do that. This is some of the parameters, these particular cases I have done. And this is the case I said. This patient has been treated on the other eye before. The other eye was also a keratoconic eye with conventional PK. And he has a treatment 3 years ago when I've done the surgery on the other eye. So this is a video we show how this works in the Weblight FS200. If you are familiar, it's not any difficult to put, of course, the applanation under control of the microscope on the eye. Having the control through the microscope, we can center everything in the cornea and in the system. And you can see here the applanation time, in real time here. This guy is going now oblique, and it's very easy to separate the donor here. And you can see very nice, there's a very regular gap here. This is 7 to 9 millimeters. So the central opening is 7, and the peripheral is 9 millimeters. So I have here 1 millimeter place in which I can guide it very nice by suture. In this case, I decided to use continuous suturing, although I'm using also zinc suture sometimes. But in order to avoid, let's say, more astigmatism, I was trying to use this old technique I was used when I was in Zurich many years ago. And this is day 1 and the day 9, and then this is the last control in which you can see here, see very nice, this very precise fitting of this Z to the recipients to the donor. And this is the OCT photographs in which you can see here, of course, that is something which you expect here. In the periphery, the peripheral cornea of the keratoconic eye is thinner, and the donor is thicker. So what is very important, I think, and this may affect a lot the final outcome as far as concerns the astigmatism, is that here we have a very nice fitting in this case, which is if you go to high magnification, you can see here that we have, at least in the anterior part here, 1 by 1 fitting between the donor and the recipients, which means that here you have equal stress, let's say, between the two tissues here. And of course, this eliminates all the forces and all the biomechanic effects. And I think this makes less stress general in the area. And of course, you have less astigmatic information in this case, which is, as I can see here in this particular case. This is the femto-assisted eye. And you see here that this is a normal PKPA eye for the other eye, which has been did 3 years ago. And of course, it's obvious that the result here is better with the last eye having quite good vision with very low astigmatism after 3 months of follow-up, and very good also uncorrected visual acuity. So you can see here some high magnification scanning electron microscopy pictures from the recipient cornea here to demonstrate how precise you can make this cut. So you can play a lot with the parameters of the lasers. And I think that this is another tool, let's say, these machines in our hands to find ways to make better procedures for the future. Thank you very much.
Tenemos 5 minutos para preguntas.
Do you take in account that the donor tissue has a certain amount of edema? Do you consider that in order to prevent that step in the back that your OCT showed.
I'm sorry, I'm hearing here Spanish. You speak English?
Yeah.
Oh, sorry.
Perdón.
Okay, say in English, yeah.
Perdón, Yanis. Now in English?
Yeah, whatever.
How do you take in account? ¿Cómo consideras el edema? Ya, perdón, yo me equivoqué. Ya estoy tan acostumbrado a hablar con él. You have your translator?
All right,
Okay.
go ahead.
¿Cómo consideras el edema que persiste en el donador para evitar ese escalón posterior que mostraste en el OCT, Ioannis? Porque nosotros considerábamos 30% de disminución del espesor.
Exactly. That's why the parameters I'm using for the donors, they are 30% bigger than the ones in the recipients. We consider that we have some edema on the corner. Yeah.
¿Alguna pregunta sin molestar con el traductor?
And also the sizing of the cut is 30%, not only the depth, but also the sizing.
¿Alguna pregunta sin molestar con el traductor para que no tenga que estar quitándoselo y poniéndoselo, Iván? César.
¿Tienes algún problema cuando la córnea no tiene buena transparencia, que no puedes ver la pupila para centrar con el femto?
Not really. We don't have so many patients, by the way. We have just a few patients done with this technique. But we don't have any problem with this particular laser, I think.
Ioannis, ¿en qué momento es el momento ideal para quitar las suturas cuando tenemos este tipo de perfil?
This is a very good question, by the way. Normally, I remove the sutures after 8 months in these continuous suturing profiles.
¿Y existe riesgo de si se quita antes tener algún problema de deslizamiento o de rotación del trasplante?
I don't think any risk because we have a very wide attaching area. I mean, the surface which the donor touch the recipient is very big. You know, it's 2 millimeters plus one on the vertical cut is like 3 millimeters. So you have let's say a surface tensile strength which doesn't allow the donor to go around. The idea with this technique is to have less sutures in the future. So this was a keratoconus